Welcome to the Elizabeth McGowan Training Institute at Morningside Ministry. mmlearn.org's distance learning is proud to offer a 4-module series dealing with behavior problems, dementia, and mental illness in long-term care. These modules are going to address skilled nursing, assisted living, and in some instances you'll even see it applies to residents we serve in independent living. The presenter we're delighted to have is Dr. David Smith, a geriatrician, certified medical director, and author on this subject. And most important to you, he's a great speaker. He's going to hold your attention and bring incredible examples, and he leaves you knowing that he knows what you are dealing with. That's most important. The first module deals with behaviors in dementia, the causes, identifying problems as they relate to admissions, MDS, change of condition. You're going to learn the possible etiologies or causes of dementia and those conditions that might just be masquerading that we can better address. Very important, very interesting in this module are addressing aggression and predictors of violence. This is essential for personnel to watch, and it's a great risk management tool as well, for sure. The second module deals primarily with drug treatment, chemical restraint issues, how marital relationships affect behavior. This is an interesting topic and one we don't often think about. And there's a great overview of the dysfunctional family dynamics and how do behaviors affect the staff and you. In the third module, Dr. Smith reviews and explains testing such as the mini-mental, the slums test, geriatric depression scales, and many others for your review. Pharmacological therapy will be explained in regards to mandated informed consents, and most interesting is the therapeutic windows of drug treatment. The final module talks about activities, and this is great if you have activity coordinators as well as the rest of your staff, and the prevention of mental illness using these activities. You're going to learn a great deal about the environment and non-pharmacologic interventions. These are the interventions we all look for and need in handling these challenging behaviors. Each module lasts approximately 1 hour, and you'll have slides addressing the objectives for each module, and I'm now going to share the required disclosures that we have to give you. So the program that you'll be seeing in 4 different modules is behavior problems, dementia, and mental illness in the long-term care setting. If you have cell phones or pagers or any other distractors, turn those off now so you can actually enjoy the series. As we told you, our presenter is Dr. David Smith. And this is approved for contact hours, and you must take the entire program. You're required to sign in, and you've done that by registering online. You'll be required to complete an evaluation and a post-test at the end of the program. Your evaluation sheet and post-test are required before you can receive your certificate. So now let me share the disclosures quickly with you, but there were no conflicts of interest evident in the development of the content for this activity by the planning committee members or presenters. There's no commercial support that was received by EMTI at Morningside Ministries for the activity. There are no endorsement of products, and there's no off-label use that's related to the content of this activity. What's great about the programming through mmlearn.org is if you want to ask a question or make a comment, you can do that. And if you want to send us an email, just click on the email, and I will tell you that you usually get a response within about 72 hours or shorter. What do you think? We always want to know what you think, and so at the top of your screen you're going to see this request for survey. We ask you to fill those out so that we continue to bring these programs to you. Remember, it takes less than 5 minutes. And the objectives, as I told you, for each program will be listed prior to the start of each module. So thank you very much. Enjoy and let us know what you think. Thank you. Bye-bye.
Shifting gears again, pain perception. The neural pathway for pain is, so I'm going to work from the bottom of the slide up, is from a peripheral receptor. There's a pain sensor in my finger, and I touch a hot stove, and that pain sensor is activated by that stimulus, and a pain sensation travels up nerve fibers, up an axon, and eventually reaches the spinal cord at the appropriate level for wherever the peripheral receptor is. Now the spinal cord, the pain fibers go up the dorsal spinal thalamic tract, which is on the back side, the posterior side of the spinal cord, and travel up, and they go into the low brain, the archaic or ancient part of the brain, the thalamus. And it's sort of like a transformer for these signals that then moves on up into the medium old part of the brain, the limbic system. Now I want you to notice that the limbic system is part of the route that this pain fiber is going to take up to the cortex, up to not the motor cortex, but the sensory cortex, where now my thinking brain can say, oh my God, I touched a hot stove with my finger. Because you know where that is because of that place in your brain. But the limbic system, the place that that pain sensation was just before it got to the conscious level, is a part of the brain's system that is shared with emotionality. And therefore, pain has an effect, an integrated effect with emotionality. And so when you have pain, you are irritable. The wounded dog, even though that dog loves you, you go monkey with him, he might bite you. All of us experience a measure of crabbiness when we have pain or are ill, and there's a built-in neurological reason for that. That way, if the archaic or ancient animal had this pain sensation, they would cocoon up in their little cave until they got better, and they wouldn't be out there risking themselves in everyday life. Anticholinergic drugs are another cause of many of the psychiatric, psychological problems, behavior problems we see in geriatrics and in long-term care. And it's important to recognize how many of the drugs that we commonly use in geriatrics are anticholinergic. It's important also to remember that acetylcholine is the neurotransmitter that is most important to memory. And it is the neurotransmitter that is most deficient and believed to be the root cause, that deficiency, the root cause of the cognitive problems with certainly Alzheimer's disease and probably other dementias as well. And so these are drugs that are anti-acetylcholine. The antihistamines, the drugs we use for allergies, are also anticholinergic. Antimuscarinics, that is the drugs that we use for urge incontinence, your oxybutynin and tolterodine and so forth, are, in order for them to have their positive action on incontinence, must be anticholinergic. Otherwise, they wouldn't do their job. But there are a lot of other drugs that we use that we don't even think about as being anticholinergic because it isn't necessarily bundled to their medical purpose. Digoxin is quite anticholinergic. Theophylline and ipratropium are actually anticholinergic because that is how they work on COPD. Many of our psychotropics, the antipsychotics, the tricyclic antidepressants, and even some of the other antidepressants, like particularly Paxil, are quite anticholinergic. Anti-Parkinsonian medications are many times anticholinergic. Not your Sinemet, but your other ones, Artane and such. And in fact, there are a load of other anticholinergic drugs that we use, and it's important to recognize that this is kind of like the new math that your kids come home with. This isn't 1 + 1 doesn't equal 2. 1 + 1 = 3 or 4, because these things pile up and enhance each other. Shifting gears here, positive consequences of restraint. Restraints used to be widely used. We've pretty much extinguished them, but not totally extinguished them yet in long-term care. They were, in the past, a visible indication that something was being done. Minnie was falling down. We fixed it so she couldn't fall down. All you got to do is look at her. And you can see she can't fall down anymore. Not true. They had proposed, purportedly rather, an immediate effect. Once you stuck the restraint on, it was working. They were fairly inexpensive. They still are. They are reusable. You can throw them in the wash and use them again. They used to be the normative standard. Facilities used to be cited for not restraining somebody who had fallen and had administrative sanction as a result from the administrators and DONs. But they come with a pile of negative consequences. And I'm teaching all of this not because they are so widely used anymore, but because they still are sometimes used, and because we all want to know where we don't want to go back to. Physiologic consequences would be immobility and all the consequential things there, so that people lost strength, they developed contractures, they got bed sores, they lost their ability to maintain their balance, had cardiovascular decompensation, and if you put people down, they actually decrease their blood volume and develop postural hypotension and therefore falls when they aren't in the restraints. They developed dependent edema. They got incontinent of bowel and bladder simply because they couldn't arise to go to the bathroom. That led to, other things led to appetite and malnutrition. Decreased immune response to infectious disease because they couldn't get to the water picture, were totally dependent upon caregivers, potentially dehydration and fluid maintenance problems, and a decrease in the basal metabolic rate. They had physical consequences like abrasions, skin tears, and actually people in restraints have EEG, brainwave changes. And when we did some careful study on restraints a decade or two ago, it became clear that although you may decrease the number of falls when using restraints, you actually increase the number of falls with injury. And there are a significant number of known strangulation deaths in the country each year, certainly reduced greatly from when restraints were commonly used. But I pointed out to you that it's likely that whatever the recorded number of strangulations is, the actual number is probably quite a bit higher because the potential for aide staff, nursing staff, or even higher levels of the administration to cover up a strangulation death and not report it as such would be fairly likely. Psychosocial consequences of restraint, and certainly an increase in agitation, particularly in the early stages of restraint when the patient hasn't resigned themselves to this. They'll struggle against it. If you want to turn a combative or a pacing or a wandering person into a screamer, put them into restraints, and you'll change the behavior in that way. Anger, aggression, verbal abusiveness, screaming, and finally resignation and withdrawal, which gets the problem out of your face but certainly does not improve the quality of life of the resident. Leads to depression, decreased interaction with others, and actually the restraint itself gives an appearance of infirmity or a lack of capacity that may not be the case, at least not as bad as it appears, and therefore causes the interactions of all other people with that resident to be less rewarding. Shifting gears, new subject. I'm not an expert on marital relations. I think that my significant other would be the first one to say that. But I know something about it as a therapist, and the marital relationship does become an important issue in behavior problems and behavior problems associated with dementia in long-term care from time to time. Probably not one of the most common things we see, but it does occur. Sometimes both members of the marriage are residents in the same facility. Sometimes, much more often, one is a member of the patient base in the facility while the other resides at home in the community. Marriage is predicated on attachment. We form a bond with our spouse, which is romantic, it's financial, and it's social. And the entire marriage is, and all of the positive things are based upon that attachment. For all marriages, there is a competing balance between intimacy and independence. We want to be part of the marriage, but we also want to be our own person. And early in marriage, there's a process of negotiation where a homeostasis is developed about that balance, so that you're both your own person, your own entity, and also a member of the marriage. As various stressors from the outside challenge the relationship, there may be unconscious fears about disconnection, connection, disconnection, and separation of this attachment. A word about power in that negotiating process. The negotiating process is occurring all the time. Most of the time there isn't much of it going on. When something's happening, there's more of it going on. And when there's more of it going on, both parties have some power in that negotiation about the relationship. But there is an old slogan that he who loves the least has the power, because of the fear of separation, the disconnection, or the breaking of the attachment. So as a therapist, you always want to look for that because the measurable level of attachment and love is not necessarily equal in the two parties, and therefore the power is not equal. Doesn't mean it's wrong, it's just the way it is. Now, in good marriages, there's a pattern or automatic maintenance of this balance of power in the marriage. But an external stressor can cause that to change. And there has to be that renegotiation process and then a restoration of that balance of power after a conflict or a crisis has occurred, such as placement in a nursing home, where one of the members of the marriage is still at home. There's going to be a thing going on there that we need to be alert to and perhaps facilitate the quicker and more healthy reestablishment of that automatic balance of the attachment. So there are health facilitating balances that enhance our personal mastery and growth in the marriage process, and those of us who are caregivers can be alert to that and help our married couples, one or more of which is in long-term care, to deal with this. Balance, which copes with external stressors, is actually a good thing in some ways because, you know, like Nietzsche said, that does not kill us strengthens us. Same thing is true when a marriage is challenged in some ways. You go through this renegotiation process, you come out of it with greater intimacy and with greater individuality than perhaps when you went in. The marriage needs to be predicated, of course, on shared values, beliefs, attitudes. Okay, new subject. Let's move on to dysfunctional families. A dysfunctional family may be enmeshed. I'm sure you've experienced families where members of the family are there at the nursing home at all hours of the day or night, and they're doting upon the resident and critical of the staff and so forth and so on. And you may come to a realization that this is because the family is enmeshed in an unhealthy way. In those families with enmeshment, you will see loss of generational boundaries. The parents aren't the parents and the children the children. It's like everybody is the same level of power and hierarchy in the family. Enmeshed families tend to be rigid, or conversely, they may be totally chaotic. So they may be overly regimented as a way to bind the family together with excessive cohesion, or they may be just totally bouncing off every wall. Enmeshed families lack privacy and individuality. Everybody knows everything about every family member. They know where everybody is at all times. They can't get along with individuality or secrets or privacy issues. And in a lot of these families, you will see triangulation or scapegoating, where one member of the family becomes the black sheep and everything gets blamed on them. Or you'll see camps. You'll see families in which several of the kids are enmeshed together over here and are battling with several of the kids and one of the parents over here about your resident in the nursing home. One of the techniques I find very fascinating when I get that kind of a situation, or I think I've got that situation, is I will set up a family meeting and I'll make sure that the meeting room is totally furniture's in chaos. The chairs are this way and that way, and there's a table there in the middle of the room, but the chairs are everywhere, and obviously when people go in, they're going to have to rearrange the chairs and set them up to the table in order to sit down and have the meeting. And I make sure that I and my nursing staff or co-therapist, whoever, is the last people, we're the last people to come in. We give the family time to get in there and set up how they want to set at the table. And it's amazing, but the people will set up and tell you with their placement of themselves at that table who is in what camp with who, who's allied with who, and who's the enemy of who. Your game's almost over by the time you walk in. Another kind of dysfunctional family we need to be alert to is those who have had family violence within the entity. And I've alluded to this in an earlier slide. We have an issue of abuse and victim-perpetrator issues. And we need to be alert that those who have been perpetrated upon, when they become empowered, may become perpetrators. I'm sorry, those who have been victimized, rather, perpetrated upon, may become perpetrators later on. The elder who is now your resident in the nursing home who has been abusive to their children when the kids were little. You know, you've seen that bumper sticker, be kind to your parents, or be kind to your children, they're going to pick your nursing home. Well, this is for real, because if you have been an abusive parent and now your responsible party is your daughter who hates your guts because you used to beat the tar out of her with a razor strap, all of her decisions on your behalf may not be very good and in your best interest. And those of us who are caregivers need to recognize that and not go in as if that perpetrator is a criminal, but understand where they're coming from and why they're doing it, and hope to correct the situation so that this family can get resolution and reach a different state of grace before somebody checks out and the game is over. Conflicted surrogate syndrome. I wrote an article along with Sam Kidder, who used to be at one time the head pharmacist at HCFA, now CMS, when the OBRA regulations were written. I was co-chair of the organization the multi-organizational committee that put that original part of the legislation together. And Sam and I developed a lifelong friendship. Later on, he became an ombudsman in retirement up in New Jersey. And he called me one day and he said, have you ever seen a family that causes so much trouble with the nursing staff that the nursing staff start to shun the elder or start to be negative to the elder because they're so mad? And, oh, yeah. I said, well, yeah, I've got a couple of them right now. What do you got? And he explained a couple of cases that he was seeing. And we, after looking at this in a number of ways, we decided that there probably is a syndrome, and it's similar to Munchausen in the sense that the pediatrician has a Munchausen case. The kid isn't really sick. It's the mother that's sick and makes the kid look like the victim or like the sick one. And so in this case, you've got somebody else in the family or an important person in the life of an elder nursing home patient who has got the pathology, and you, the caregivers, don't have them as a patient. But their actions are having a negative outcome on your patient. Therefore, you have to give certain attention and ministrations to that other person. There are many causes for this. One of them is this past victimization, now turned perpetrator situation. The most cliche one, of course, is the family member who feels guilty about putting their family member in the nursing home. And so now nothing the nursing home staff can do is right because they could have done it better. And they've got to make that point, so they're all over you all the time, haranguing you and maybe calling the 800 number and making complaints against the nursing home and so forth. I actually had one woman whose husband, a dementia resident, had been kicked out of 5 prior nursing homes because of her. And she had called the 800 number more than 100 times, resulting in more than 100 state investigations of this or that nursing home. And it turned out that her problem was that she and her husband, the demented resident, were not first marriages, but rather a second marriage. She had been his secretary. And they had had an affair and broken up each other's marriages and then got married. And she had been his wife for some 20 years. But now in his dementia, she was trying to prove to his adult daughters by his first marriage that she wasn't a homewrecker. that she truly loved him, and so forth. So her motivation was to be very, very critical of the nursing home staff in order to prove to the daughters that she was being a wonderful wife to their father because she loved him. And I ended up doing therapy with her. She wasn't my patient, but I ended up doing therapy with her to teach her that you catch more flies with honey than you do with vinegar. If your stepdaughters don't know that you love him by now, they never will. A variety of things messages that I did in cognitive psychotherapy until we got the problem reduced down to a dull roar. But the missing part of the puzzle is that I want to see a time when this problem can be identified with a diagnosis and there isn't a mandatory investigation for these chronic complainers, because the investigation actually stimulates the behavior. It rewards it and causes it to occur more. It's counterproductive, anti-therapeutic. Summary. Some of the reasons for behavior problems in dementia are cognitive loss and misinterpretation of the environment. I said before, that's the big one. Psychological or past personality explanations, cultural and social systems explanations, unmet physical needs, pain, a physical illness with functional deficit, a physical illness with psychiatric symptom, a medication side effect causing a psychiatric symptom, a mental illness with comorbid to the dementia, or any combination of the above. This is not simple. Moving on, we'll go to consequences of behavior problems in long-term care. What do these cause? Bang, 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 help me, help me. We've heard this kind of screaming, and one epidemiologic study showed that this occurs in 11 to 30% of residents at some time in their stay at a nursing home. This obviously has an effect on the milieu, on not only the staff, but the other residents and the visitors. Maybe one of the reasons that everybody thinks a nursing home is a bad place. Behavior problems occurring with dementia, I've said before, is the single most common cause of nursing facility placement from either the home environment or from an assisted living facility. And it is the most important time sink for staff. Of the things that staff do that might be remedial, that might be fixed, this one takes up the most staff time. It's also true that staffing is either the largest line item on the expense sheet for nursing facilities, or it's one of the largest line items. And so these behavior problems represent probably the most opportune thing that we could do to improve the bottom line for a nursing facility in terms of its financial well-being, let alone doing it for the sake of the quality of life of the residents. The impact of behavioral problems in the nursing facility is that behaviors often require the attention of the RN, the CNA, the LPN, or the CNA. And the most frequently reported behaviors are physical agitation, refusals of care, and requests for unneeded attention. But the most costly behaviors are physical aggression, psychotic symptoms, sexual disinhibition, and depressive symptoms. Now, when we determine the per diem, the pay that a nursing home gets for caring for an elder, this has changed somewhat, but it's about concept here. This is determined based on resource utilization groups, the RUGs, in most states. The various RUG groups are attached here with special rehab 14, extensive services gets a 3, special care 3, etc. And you look here and a behavior comes in at about a 4. And I want to propose that this is inadequate. It does not really represent the sucking up of resources from a nursing facility, and therefore doesn't incentivize a nursing facility to diagnose it, to put it on the care plan and do something about it, and therefore be rewarded for it. Now, the MDS 3.0 has been implemented October of 10, and we're going to see what effect that has on this, but I'm not particularly impressed right now that that has been one of the big advantages of that change. The motivations under prospective payment systems are to manage outcomes rather than expenses and to look for value, and I think this particular issue, solving behavior problems so that they aren't a drag of expense in terms of staff time, represents one of the biggest opportunities that a nursing home has. The impact of behavior problems on the nursing staff are that the staff caring for elderly patients with these problems may feel very frustrated, helpless, unable to extricate themselves from the problem or to help the patient. And that might lead to them withdrawing from the patient or the problem, or in resulting provision of minimal care. They just don't get what they need. There could be an over-reliance on physical or chemical restraints. When we as caregivers, and in fact, the reason that most of us got into this field is because we're kind of do-gooders, and we get paid not only a paycheck, but we get paid by our patients, our residents, with gratitude, with acceptance, and with patience. And that's kind of our expectation. It's kind of what we think people owe us for being whatever kind of caregiver we are. But many times the resident doesn't give us those positive feedbacks, and instead we get aggression or combativeness, verbal abuse. This could lead to anger, to retaliation, to defensiveness. But if we are professionals, we need to understand that the behavior, except in a competent resident, a totally competent resident who is doing this on an adult-to-adult interaction level, they're a bad person. All of the other ones, those who have dementia and psychiatric and psychological problems that are diagnosable and treatable, the behavior needs to be understood as a symptom of their disease and not necessarily totally in their control. And it needs to be our intent to try to help them to gain control over that and to alleviate the behavior problem and therefore their suffering. And not to take it personally that they have done this behavior and not given us our non-monetary pay for being a caregiver. We've got to be a little more internal in our gratification. We've got to do it because we know that's what we're supposed to do. I'd like to transition now to interdisciplinary team process. Behavioral problem solving by the interdisciplinary team process is one of the most enjoyable things that I get to do. It is at risk for being too comfortable. You can get your coffee and sit down in a room with people you're professional friends with and burn a lot of time and not get where you need to go. So we need to constantly stay alert to the efficiency of this process. Nevertheless, developing comfortable working relationships with the other people on the team and enjoying this is one of the great rewards of it. I have often said that one of the most fun things I get to do is play the guess what he's thinking game and to try to ferret out what really is what factor or most often factors are behind a resident's problem behavior. So we sit down at our interdisciplinary team meeting and we make an attempt to figure out what best explains the resident's problem behavior. A way to frame this is to think first, is this something that is intrinsic to the resident? Is this coming directly out of their pathology, their personality, so forth? Or is this something that's extrinsic to the resident? That is this really a problem with the environment or the system? Or is it, as in most cases, a combination of the two? Things are always more complicated than most people think they are. When does this problem occur? Under what circumstances? And what precedes the behavior? Now, things that are going to happen before something, there is one of the fallacies that you learn in college logic, post hoc ergo propter hoc. That is, after this, therefore because of this. But it's also true that many times what happens before an event is in fact the trigger for that event. So we need to take a look for that and see if there's a message there. Does the resident do X every time Y occurs? What exactly is the behavior? Again, I've pointed out that we need to be careful about cataloging behaviors because they're just too broad. And so if you're worrying about wandering, we need to know what kind of wandering. Is it agenda wandering, shadow wandering, or what? Pacing. Because each one of these things gives us a clue as to what might be the cause or causes. The more we know about the details of a behavior, the more likely we are to be able to figure out what caused it. So if it's aggression, if it's striking out, does the resident strike out at random people, or do they strike out, do they seek out and whack on just one particular individual that's their enemy? Do they only whack on people that they perceive are weaker than they are, or are they indiscriminate? Do they only pick on people of the same sex or the opposite sex, or what? Each one, you can see that each one of these things kind of generates a different thought process as to what the resident might be thinking, what might be the cause of the striking out problem. Then we ask ourselves, what happens after the behavior? And we need to know that because what are the consequences? How big of a problem is this? For some behavior problems, there really are no significant consequences, and so although the behavior is quirky, it really doesn't necessarily deserve our attention or remediation. But if the behavior is causing or could cause a bad consequence, then we need to consider it more importantly. We also need to look at what happens after the behavior occurs to see whether that might be a reward for the behavior. It may be something that is being achieved and therefore driving the behavior to recur. Naughty little kids throw temper tantrums at the grocery store in order to get mom to buy them the toy that's hanging on the rack right there at the checkout counter. That's why they hang them there, to create that behavior. If you give in to that behavior, you're guaranteeing that there'll be a temper tantrum every time you go to the grocery store at the checkout counter. Going back to consequences, when we look at consequences, we need to ask ourselves, worst case scenario, what's the worst thing that could happen as a result of this behavior? And again, ramp up our concern and the seriousness of our inquiry, as well as the strictness of our fix for it in order to prevent that worst case scenario. So, for instance, if you are having an elder who is trying to exit the nursing home and your nursing home is in a nice quiet neighborhood and a semi-rural part down in Florida where there's no significant problem if they do get out and walk a few blocks away, well, that creates less risk and therefore less intense approaches to handling the behavior than if you have a resident that's trying to exit the building in South Dakota where it's 7 degrees below zero outside and there's a cornfield 8 feet away from the front door of the nursing home. They get 3 rows into the cornfield and you'll never see them again. So the consequence, the worst case scenario, deserves our attention. One way to think of this is the ABCD of behavior. That's not on this slide. You may want to write it down now. This comes from the AMDA Clinical Practice Guideline, the ABC, and then we added the D to it more recently. A is antecedents, B is behavior, what exactly is the behavior, C is consequences, and D is disaster, worst case scenario. Antecedents, behavior, consequences, disaster. ABCD. Behavioral problem solving by the interdisciplinary team process also includes a diagnosis review. We look through the known diagnoses and ask ourselves whether this behavior might be attributed to a known mental disease, whether that might be from a physical disease, or whether a physical disease is causing mental symptoms. Hypothyroidism causing depressive symptoms. Hyperparathyroidism causing psychosis. We do a drug review. What medications is the patient on? Could the behavior be a drug-induced mental symptom? We need to stay on the constant alert for this, and it's important to look at when were drugs started and when did the behavior begin to express itself. And if you know when a drug was started and how long it takes to reach its steady state, then you may also be able to see that, you know, let's say 11 days after Prozac was started, that such and such began to be evident, and that would match to the drug as potentially a psychiatric symptom caused by that drug. Inadequate or incorrect drug treatment of mental illness. Sadly, many people with depression are known, recognized, treated, but they're only halfway treated. And so residual symptoms occur. Or drugs are being used for chemical restraint when a different drug might actually attack the neurochemical deficit that the resident has and improve their situation. So the dementia patient who's combative and it's caused by an underlying depression might be getting an antipsychotic just simply to try to suppress the behavior by sedation, by chemical restraint, when they might thrive if they were off that antipsychotic and receive an antidepressant, for instance. When we are implementing behavioral approaches, consistency is the most important. The folks out in Las Vegas are very rich, and they're rich because they're smart, and they're smart because they understand human behavior, and they know that the way to reward a behavior and make it keep happening is to randomly reinforce it. What I'm talking about here is, it applies to all the forms of gambling, but let's take the one-arm bandit. You pull the lever, and the thing goes round and round and round, and part of the time coins drop out, and you're rewarded for putting money in and pulling the handle by an occasional random reward of more money coming out, plus some interesting little sounds and lights flashing and stuff that keeps us all excited. Now, the machines that are close to the door are set looser so that when people come in and they're trying to catch you and get you into the habit of pulling the one-arm bandit, you're rewarded more often. The payouts aren't very good, but you're rewarded more often. The more you move into the center of the casino, the tighter the machines get, although the rewards get a little better, and they have learned that they can randomly reinforce your actions and get you to keep pulling the one-arm bandit. And if they put the machines right next to the cafeteria, to the restaurant line, where you got to stand in line for 10 minutes to get in to get a seat in the restaurant, then they can make those machines so tight that they almost never pay off, and people will keep pulling them because they're standing in line. So if we have a behavioral approach to extinguish a behavior, and it includes not giving unnecessary attention and eye contact and verbal stimulus back to a person that is misbehaving, because just like a naughty child, an elder may do bad things in order to get attention. So if our care plan says we're not going to do that, but there's one nurse's aide on the night shift that either doesn't get it or doesn't agree, that behavior is likely to continue. And as a matter of fact, if the resident gets that random reinforcement periodically, they're liable to increase the bad behavior because all they can see from their standpoint is that, gee, if I do it more, I can finally get rewarded. It'll finally happen. Consistency is extremely important. I wanted to talk a minute about the reasons that primary care doctors should do a lot of the mental health care that we deliver in the long-term care arena. Many times our primary care physicians may not come with the skills for this, or may not really want to do it, may not take ownership of the problem. And certainly remuneration is such that unless you're skilled at it, getting involved in these particular areas of care is not particularly financially rewarding. But there are some good reasons that family docs and internists in the community should become expert at this and do it. One is logistics, because there are a lot of us, and there really aren't very many psychiatrists. It's also true that we already have a ready-made rapport with our patients. They're already our patients. We've had an experience with them in delivering other kinds of care, and it isn't a big change. It's not a paradigm shift for us to begin to deliver care that is psychiatric or psychological. In the current group of elders that we find in the nursing home, there is probably a pretty significant bias against psychiatry. Now, maybe as the baby boomers reach the age of nursing home placement, that will not be true, but currently it certainly is, and psychiatrists are the butt of jokes, and it's considered a stigma to see one. And so it may be better to just let the family doc or the internist who has cared for you for a long time handle this and not get into that whole bailiwick. By being the primary care doctor, you're there when the problems begin, and it's always better to nip things in the bud. It's also true that these problems are common. We've talked about that. It's the most common reason that people get in the nursing home is behavior problems associated with dementia. If we look at the definition of family practice, it says that we're supposed to be experts in the common diseases and problems of individuals and families. And I put it to you that there are very few of the clinical problems that we run across that are not as common as this one. It's also true that common doesn't equal simple. There's no connection whatsoever. And so because this is complex doesn't mean we cop out of it, because in fact it is common. Finally, family doctors, the whole specialty of family medicine is designed around the concept of biopsychosocial integration of our assessment and treatments for the various conditions that we run across, and this really should be in our skill set. When we have problems that we do find that are beyond our grasp, there are other resources to help us with behavior problems in the long-term care arena. We can get a general psychiatrist there, but I caution you that general psychiatrists come with a wide array of skills when dealing with geropsychiatry. Geropsychiatry is really very different. It's much more integrated to the physical problems that the residents also have. And many general psychiatrists are just not up to that. On the other hand, there are some that have made an effort and are quite good at it. So we need to know the individual doc there. If a doc really holds himself out to and has done extra study and become a geriatric psychiatrist, I think we can automatically raise our level of trust quite a bit. Geriatricians, and I would call myself one, are also likely to have significant skills in this arena. The problems are common, and it's part of our curriculum. Part of the curriculum, if the doc has done a fellowship, as I have, it's part of the curriculum if you have made an effort to achieve the Certificate of Added Qualifications in Geriatrics that's jointly offered by the American Academy of Family Practice and the American Board of Internal Medicine. And it's to some extent represented in those docs who have made an effort to become certified medical directors through the American Medical Directors Association. So those are credentials that I would look for that are likely to be a signal for increased competence in this arena. Pharmacists have recently, the American Society of Consultant Pharmacists has recently created a program and a test that allows a pharmacist to achieve a level of added qualifications in geriatrics. And I would look for that, and if there's an administrator or a DON that's looking at this, be aware of that, and if you have a consultant pharmacist who ain't one, I'd be asking them to become one, or perhaps look for another contract if there is any concern about the quality of your current guy's work. Psychologists can be a resource, but let's be careful. There are getting to be a significant number of itinerant psychological services out there that spend a lot of time, what shall I say without being overly derogatory, spinning their wheels, giving psychotherapy to patients with an MMSE of 4. And if you look at their progress notes, every note looks the same. I don't like to see that. I like to see individualized efforts. I like to see collaboration with the nursing staff and with the physicians so that initially a psychologist might spend a great deal of time getting an assessment on residents, dealing with the residents, and then depending on the problem, might spend relatively little time at the bedside with the resident and a lot more of their time working with and guiding the staff in delivering care to the resident related to their psychological psychiatric problem. Medical social workers can have special skills in this area, and certainly another of the resources is developing a competent and comfortable team to do the interdisciplinary teaming. Some of the barriers to interdisciplinary teaming are these. There's certainly a problem with logistics. It's very difficult to get the physician at the table at the same time we get the social worker, the charge nurse, maybe the DON, certainly the aide staff member who has spent the most time at the bedside with the individual, and get them to all sit down at the same time, bring in the family, bring in the patient themselves for part or all of the conference, and tackle this problem. That's a huge commitment in coordination that is difficult to implement and doesn't always occur. Getting families there is critically important. They supply corroborating histories. They tell us what the resident was like before they had dementia. Who were they? What were their preferences? What were their coping skills and so forth? They're the only way we would ever know that and get that input. And they're also needed so that they can approve or disapprove of the plan of action, the care plan that we construct during the interdisciplinary team process. If there are psychotropic drugs that are going to be delivered, the family, the responsible party, needs to give permission for that after they have received a full informed consent about side effects, about the expected duration of therapy, about alternative treatments that could be used but are not necessarily recommended, about the potential side effects of the drug, and such, and the expected result. All of those things are actually required by Texas law to be given before a family can appropriately, or a responsible party rather, can appropriately consent to the use of psychotropic drugs. We need to remember that even a mentally incompetent elder can refuse an antipsychotic drug. They may not be given those against their will, and all that it takes for them to refuse it is to go, They don't need to tell you, no, I don't want my Haldol. And so the process of giving the psychotropic drug hidden in applesauce is probably not kosher, perhaps not legal, and I would discourage it. No specific reimbursement code for physicians for the interdisciplinary team process. Now, there are ways that we can use the time spent in an interdisciplinary team and then at the same time or day see the resident and use the code that modifies a visit code, let's say a 99309, you put the modifier on it, and you need to make the documentation in your visit that more than 50% of your time has been spent in education and coordination of care. And there is a significant upcoding or boosting of the reimbursement for, and you can apply that modifier to any of the nursing home codes depending on the level of service done at the bedside. Another barrier to interdisciplinary teaming is that frequently CNAs are not included, not involved in the task, or that they lack skills, don't know what's going to be expected of them. But the CNAs are certainly the folks who are in contact with the residents and actually see the behavior as it unravels. They see what might be the triggers, what happens before the behavior. They see the consequences of the behavior. They know the nuances. They can, once they are taught how to look at a behavior and pick it apart and tell us the relevant specific details about it, they can become very skilled at this and also extremely helpful. Without them, you may not get the right answer. There is often a gap between excellent interdisciplinary teaming and care planning and then the implementation process. And that may be just a matter of process, a matter of how do you take a plan and actually put it into effect in a particular nursing environment. But it also it can be messed up by the naysayers. The naysayers may be people that were at the meeting who didn't speak up and say, I don't like this plan. As this plan is unraveling, I see problems with it. I don't believe in it. I don't think it's ethical. I think there's something wrong with it from the standpoint of patient rights, whatever they decide. Or it might be somebody that wasn't at the meeting and didn't get in on the reasons for the plan and then doesn't agree with it because they are ignorant of the real purpose. I have most often seen this when the behavior problems revolve around smoking. And the naysayers are almost always individuals who do themselves smoke. And so they get very adamant about resident rights in regard to smoking, when actually smoking is a privilege and can be dealt with by admission rules and regulations and so forth. Nevertheless, for whatever reason, naysayers, it's not wrong to be a naysayer. I'm not suggesting that one should not be a contrarian. But the proper way to be a naysayer is to say, I don't agree with this plan as it's being proposed. Tell the reasons why. And then if you get outvoted, because the team is, in a sense, a democratic process, although I conceive of it as a benevolent dictatorship, that the attending physician is still the captain of the ship and responsible for it. And so in the end, it is the attending physician's order that puts a behavior plan into effect. But the naysayer must go with the wishes of the majority and the chosen care plan, and must perform their tasks related to that care plan to the fullest degree of their ability. So you don't sabotage a plan you don't agree with. To do that is unprofessional, unethical. It is not wrong to be a naysayer and to say why you don't agree with the plan, but you need to participate in the plan as if you did agree with it. And then your mission as a naysayer is to outline for the treatment team the timetable by which you would re-examine the plan for its efficacy and its consequences, its utility. When should we look at this again? What would be the measures that we would determine that the plan is no good and that I'm right and all you guys are wrong? And then to make that happen. And those who are in the majority cannot dominate the naysayer and refuse to do that. A naysayer should also not be nihilistic and say, well, I don't like this plan, but I don't have anything to offer in place of it. A naysayer needs to have an alternative in order to be a constructive and professional naysayer. Enough said about that.